Today we have Skip, an old friend of ours who's got a problem with his left shoulder. He's describing some pain in the lower rotator cuff here. He's getting some tingling, sometimes numbness in the hand, not able to really distinguish where the numbness is. Back of the hand, front of the hand, he just occasionally loses sensation in the hand. In terms of his general health, there's some pro-inflammatory influences going on, which means there's some contraindication to really deep work or trying to break up too much adhesion because his body would have a hard time resolving whatever minor inflammation that we would instigate. So we're going to be conservative, but we're going to be direct. But first we need to figure out exactly what's going on and what we're working with. So Skip, if you could just raise your left arm up over your head, just as high as you comfortably can. Okay, so hold it there. Does it go any higher? Okay, so if you can hold it for a second, the first thing I see is that a lot of upper trap activity here and not as much movement in the scapula as I'd like and not as much movement in the glenohumeral as we would like. So I would say for sure we're overworking here, some scapulothoracic or maybe acromioclavicular restriction. We'll also look at the sternoclavicular joint because that's so important to all shoulder movement, and the glenohumeral as well. So in terms of joint issues, it kind of looks like the whole thing is a little bit stuck. Just generally looking at it, it does look a little bit swollen right through here, not terribly so, and also right through here. Can you raise your arm up over your head again? And I'm gonna see if I can kind of get a sense of that end feel. And yeah, right in here, there's a lot of tension. So his triceps here and his latissimus here. And we're going to be looking at this section right here where those two meet. The neurological symptom in his left hand indicates there's some nerve entrapment somewhere. And a lot of nerve entrapment happens here between the triceps, the lat, the teres major, and the teres minor. Always looking at neck stuff with shoulder stuff. So just going to do a little gentle motion palpation here. Here's C7, T1, and you can see, I know it's not easy, Skip, to just kind of let me move your head, but as I try to side bend his head to the left, there's not a lot of movement right here at the cervico-thoracic junction. So we're going to try and open that up. And rotationally as well, right here kind of tying into that upper trap hyperactivity that we noticed when he lifted his arm straight up. This whole thing of his upper trap is, it's tight. It's, I would say, overused and restricted. Can you tuck your chin and kind of let your head just fall forward? Okay, and we can see just as soon as he starts to flex, this upper trap just pops right up. So that's restriction in that upper trapezius muscle, probably from chronic congestion leading to adhesion and getting into that cycle of restriction, congestion, adhesion, leading to more restrictions. So our initial assessment is that it's not acutely injured. There is an old injury to it, a basketball injury. Perhaps it was subluxated, but it was certainly hyperflexed. And so we got to keep that in mind. It might be a little bit of instability underlying. But otherwise, aside from the pro-inflammatory stuff we talked about, I think we have a green light to get to work. So I would love for you to lay on your right side so you're facing the window, okay? So as we get started, we want to remember that there's layers and layers of tissue here. It's all connected. So we don't want to just like immediately dive right into where we think the problem is. And we want to take a survey, also give the patient an opportunity to kind of acclimate to being touched. And especially if it's an area of chronic pain, there's going to be some guarding, which is natural and appropriate. And it's nice to give people just at least a couple of minutes of warm up, skin level, and superficial fascia. And you can get a lot of information that way too, from the texture of the skin, for example, like just right here in this problem area, the skin's kind of bumpy and pretty dry. And so that could be a sign of some insufficient capillary flow through tight fascia and restricted myofascia there. So skin sensation and skin texture can be really informative. So don't just jump into the deep tissue, but for a lot of reasons. Give people a little warm up. So here's his latissimus here, and it's good. Nice muscle. And just kind of get a sense of it as it comes up toward the axilla, and it is feeling pretty bunchy right there. So this is really the area of sensation and pain. Yeah, Skip? Mm-hmm. Okay. So we're getting close to it, and still just kind of skin level, fascial level. I want to save my thumbs as well. Your arm's okay in this position? Okay, so now let's really kind of get into these tissues. So I'm orienting myself. Right here that I'm pinching, that's his latissimus dorsi. Okay, here's the serratus anterior, and that is also going to be a little bit of serratus anterior right here, because that's the lateral border of his scapula right there. So as we come up, there's teres minor. Excuse me, teres major first, teres minor here, and then infraspinatus here. So what I really want to know is, as I take my fingers and kind of stroke, yeah, you can see that chunk right there. So that just answered my question. What is the texture of that teres major right there? It's restricted and bunchy. So there's adhesion in there within the muscle. So there's fascia inside the muscle, separating the fascicles or bundles of muscle fibers. There's fascia in between the muscles and around each muscle. It's what gives every muscle its shape and its form. And so we got some fascial adhesion in that teres major. And I'm going to follow that muscle out toward the deltoid. Here it's going to kind of dive deep to the deltoid. There's his deltoid muscle right there. And I'm also coming into the triceps. So there's just so much going on in this space right here. And there's so many different ways that things can go wrong. And a big thing that I'm finding already is that teres major adhesion. So the latissimus itself feels okay so far. We haven't really gotten to the part where it tends to be challenged, which is in the axilla where it turns onto itself. We'll get there in a minute. So here's the teres minor, and it's hard. Yeah, this muscle is hard, and I would say pretty deconditioned, quite likely being overpowered by that tight adhesed teres major. It's kind of given up. And when the rotator cuff muscles get deconditioned like this, you get a lot of instability in the shoulder, which then causes other muscles to have to pick up the slack. Skip, can you bring your elbow right here for me? And let's go like this. I just kind of want to get a sense of the strength and responsiveness of his teres minor here. So that's an external rotator, which means I want you to hold your arm right here. I'm going to let go. I want you to push your wrist back against me, okay, as I push to the floor. So instantly you can see he's starting to hunch his shoulder a little bit, and he really wants to recruit some other muscles. Give me one more push right here. And it's a little shaky. I could push through and overpower the muscle to kind of show you, but I don't need to do that. I don't want to hurt my patient, so take my word for it, that teres minor is a little bit weak. So that's another issue that we're dealing with. Infraspinatus and teres minor, they're kind of partners in crime, and they kind of do the same thing as each other. Infraspinatus, to test that, we're going to put the arm in a little abduction like this, and I want you to hold it there, Skip, and push your wrist into my hand right there, okay? So a little bit better response from that infraspinatus than the teres minor. As we're getting farther from the teres major, the better it's responding. Here is that supraspinatus, so important, and kind of feeling pretty par for the course. Bound up and a little bit deconditioned, maybe I would even say like dried out, just from lack of use and lack of blood flow. So we're here on his upper trapezius, and surprisingly, you know, it feels okay. There's going to be a trigger point right in there, right there, that we just kind of rolled off of. But it's really more the victim in this circumstance is having to work really hard to move his shoulder because it's pulling against this adhesed teres minor every time he tries to lift his arm or do anything with the arm. Let's come around and look at the front of the shoulder. You okay in this position? Good. We're looking at his sternoclavicular joint now. Here's the clavicle, his collarbone. Here's his sternum right there. So we've got this sort of a saddle-shaped joint of his sternoclavicular right there. And it's kind of on initial palpation. There's nothing particularly outstanding about it. It's not subluxated. It's not swollen. But let's just see, does it move as we abduct his arm? So Skip, I want you to let me do this. Okay, I know that's hard. So I really want to feel this clavicle turn kind of like a crank, especially right through this arc. And his just doesn't, right? So as I'm trying to abduct his arm and induce that clavicle to rotate so the inferior part comes anterior, and just trying to induce that, it actually feels like the primary restriction is much more here in the coracoacromial and AC joint. So yeah, right in there. We can feel that. Is that tender? Mm-hmm. Yeah. Okay. So we've got a few things to do. We're going to try to open up this coracoacromial arch. We're going to do a little gentle work on that teres major. Remember, we don't want to do too much, so we don't want to push the inflammation in this patient. And now we're going to get into the axilla. We're not afraid to get in there and see if we can feel the latissimus, and it's like hard as a rock right there. We would like to have a little more pliability and a little more mobility of that tendon. So right under the pad of my finger is the whole neurovascular bundle, all the nerves that feed his arm, and then they're laying right on top of the lat right there. Here's his triceps coming down here. So this section right here, we're going to try to induce just a little more softness and get some circulation and mobility through there. And since that's probably going to be the hardest part, I'd say let's start there. So you ready? Mm-hmm. Cool. Skip, can you put your arm kind of up over your head in a comfortable position, like where it could sit for a little bit? Is that okay? Mm-hmm. Is that pinching the shoulder? A little bit. It's okay? All right. So triceps here, lat here, teres major, there it is, right there. And we're going to follow it into here. So the idea is kind of like kneading dough, trying to soften it. So we're not digging. I'm not working to see how far into the armpit I can insinuate my finger. You can see I'm kind of more using my fingertips to grab the fascia and slide it on the deeper layer. So we've got the skin, then the superficial fascia, then the deep fascia, then the muscle. And where we see a lot of adhesion is between the superficial fascia and the deep fascia. Those are not just different in terms of their depth, but they're completely different types of tissue. The deep fascia is a very dense, regular connective tissue, and the superficial fascia is loose, areolar connective tissue, much more vascular. That's where a lot of the adipose cells live. It's supposed to be soft, it's supposed to be spongy, and it's supposed to glide pretty easily over the deep fascia. And that's really the main thing I'm trying to induce right now, just to get some more mobility. And it's, we're getting there. And in particular, it feels stuck right here. So we're gonna spend a little bit of time right here. And you take a deep breath for me, Skip, and let it on out. Good. Nice. One more time. Good. That's good. Nice deep breath. So now we're going to come distal, coming around, trying to stay as close to my work as I can. And we're going to work this triceps. Again, see, I'm just kind of inducing a little mobility, pulling it into some kind of like an externally rotated position, working the whole length of it. Even though it's mostly stuck here, we don't want to forget that that muscle goes all the way to the elbow. And by freeing up this muscle, we're going to free up a lot of mobility in the shoulder. It's going to be good. I can already feel that we're on the right track. And right here again, where it meets that teres major, this is our spot. So let's get some work right here. I'm going to ask you to let your hand just be floppy and just give me control of your arm. And you know I'm not going to do anything sudden with it. We're not going to make any big dramatic movements. So I'm just kind of using his humerus now as almost like a stirring spoon. I'm trying to get a little bit of rotation through the shoulder joint, and in doing so mobilizing this teres major. So remember, it's adhesed, it's deconditioned. We're not going to fix all that in one session. That's not the idea. And because of his pro-inflammatory stuff, we don't want to do a lot of deep tissue work. We're just really trying to get some blood flow through there. Remembering we haven't really addressed that coracoacromial arch yet, so the amount of mobility we're going to get through the glenohumeral joint is limited, and that's okay. We really just need about this much right now. Okay, switching hands. Okay, good. So now let's work the front side and orient myself. Here's his clavicle. Here is his coracoid right there. There's the coracoacromial ligament right there. And right here you can kind of see it just doesn't want to let me horizontally abduct his shoulder. It's holding on really tight. So as usual, the idea is we want to induce the movement while we kind of try and get those soft tissues on board. You okay with your position? Good, because we can shift if you need. Okay, take a deep breath and let it out, and we're going to come a little more. I think we got a few more degrees. We're going to start adding a little external rotation. I know this is hard. Keep breathing, and it's good. 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 And let's see where we're at with our abduction. Good, better. Getting some movement here, which is nice. The clavicle is moving. So let's give his shoulder a minute to rest. So we gave Skip a little rest, gave my hands a little rest, and I'm working into abduction now. And you can see and I can feel a lot more mobility in this section and a lot more mobility in this section. So just based on my palpation, the place where it's most stuck is right here in the triceps. So we're going to do a little work there. Can we let your arm hang like that for a bit? Okay. So before we were kind of working the triceps as a whole and inducing some mobility in this plane. And what I want to do now is a little more get into, I think what I would call this the lateral head of the triceps, and a big knot that has settled in right there. So this is tender and this is sensitive, and we're not going to try to resolve the whole thing in 5 minutes. So don't be too aggressive. Really just more about always trying to get a little blood flow in there. So we got our dysfunctional cycle of restriction leading to congestion, leading to adhesion, leading to more restriction, more congestion, more adhesion, like that. And so the way out is through mobility, bringing in circulation, which brings in reconditioning of the muscle, which brings in more mobility, which brings in more circulation. So right now what we're working on is mobility and circulation. That's always our goal. So trying to get these muscle fibers mobile in relation to each other, the muscle as a whole mobile in relation to the underlying bone and the fascia overlying it, and then the superficial fascia mobile in relation to the deep fascia. That's our goal. So let's bring this here. Good. Got a little more movement there. So now, as usual, whenever we're dealing with shoulder stuff, it eventually kind of winds up right here. So the inferior angle of his scapula is at this level, and this is where his serratus anterior crosses the lat. And I don't know that I've ever seen a chronic shoulder problem that didn't involve some restriction or adhesion right here in this space. So gentle, easy, nice deep breath. The deep breath here helps because that engages that serratus and moves the rib cage, and that's what we want to be doing. Breathing out. Good. 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 So just to reiterate, we did the teres major, through the axilla and down to its scapular attachment. A couple rounds of triceps worked on this coracoacromial ligament to get the scapula moving a little bit better. And now let's see about working on his cervicothoracic junction. Laterally flexing his neck away from the affected side so I can feel how his scalenes, levator, and upper trap are. It's kind of like, how are they feeling about this movement? And they're not super psyched. They don't love it. And in particular, there's a middle cervical segment right here that's a little stuck. Say maybe C3 or C4. And the rotational movement is not bad at all. So it's really more of a side bending, disc wedging type of a restriction. You okay with an adjustment, Skip? Mm-hmm. Okay, let's see how that feels if I kind of bring it right there. Good, good, easy. Good. So from here, I think it's just a matter of a little bit of work to the cervical extensors and a little support for this left upper trap that we know is overworking. And maybe let's just kind of treat this trigger point in this left upper trap here, which I'm doing with my left hand. I got the thumb on the anterior side of it and my middle finger on the posterior side. We're just kind of giving it a little squeeze and a little stretch. Get some fresh blood in there. Good. So follow that out. We can really see the attachment of his upper trap on the distal clavicle right there. It's nice to work that attachment. From here, I would say we should probably do this again within a week and see if we can get a little bit deeper or a little bit further into the pattern. We probably would see some issues coming up in the thoracic spine and the ribs as the scapula starts to change the way that it moves and where it wants to sit. It might run into some resistance or obstacles in terms of rib cage position. Maybe there's one or two ribs that are a little bit fixated, or maybe the whole rib cage needs to be mobilized. Working through diaphragm stuff, serratus stuff like that. But I think that's a nice piece of work for the day. And thank you. It's really good to see you.
Great to see you, DR.
Okay. Dr. Russ signing off.